yet.
Okay, perfect.
Okay, so we definitely need to wait for the board members to come. So we'll just wait a few minutes.
And I'm just going to mute myself. Okay.
Good afternoon. Good morning.
Good morning, Eric. Wonderful to have you on. You're the first board member to appear. So we're just waiting on a few others.
All right. Hey, I hate to do this. I only have an hour because I have my grant review committee for, and I have some of the grants I was reviewing. I have to hop on there at 1. So
Okay,
I've only got an hour.
okay. We'll make do.
Yep.
Cool. We have Sarah Adler joining us. Is that right, Sarah? Is that Sarah's iPad? Cool. Okay, so now we have 2 board members. I think we need to, okay, cool. And then, great, maybe Laura will join us and then Shayla's about to get on. So we probably should start videos. Sarah!
Hey.
Awesome. All right. And I just want to ask really quickly, Heather Lazarakis. Are you filling in for Kirsten Colomb?
No, I represent the Las Vegas district offices, but I work with the Reno district office as well. So I'm not sure if somebody else from LTSS is on here or not. I don't know. But if there's a question, I will happily help to answer it, or I can take it back.
Okay, awesome. Yeah, I think we just were hoping for her. Kristen Colomb emailed me, I think today, that she is double booked until it just happened, like the last couple of days, until 1:30. So I was asking if Marcia would be able to provide the information, and I didn't get a response.
This is Dr. Marcia. I'm the policy specialist,
Yay.
1915I, but I believe Kirsten was planning to be on from 12 till 1.
Oh, I maybe misread that. Is that
She had to jump off at 1.
okay?
I'm a
Wonderful.
policy specialist for 1915I. So I'm fairly new, but I'll try to do my best, but hopefully she will be on very soon.
Oh,
Thank
this
you.
meeting is saved. It's hard when you've got 2 presenters and you're like, one is gone. But it sounds like we'll have the presenters, so that's excellent.
Yes.
And Amy, the chair, is here.
Hi, how's it going? How's everyone? Thanks for getting this together, Jessica. I'm excited about it.
Yeah, totally.
Yeah,
Um,
Ms. Chair, I'm sorry, really quick, point of order. Do we need to have somebody take minutes or are we, oh, you're recording it, aren't you, Jessica?
Yes, and we have someone from DPBH. This is open meeting, so they'll do the minutes.
Perfect. Okay.
In terms of quorum, so I had listed on the agenda Nicki, Shayla, Erik, and Amy. So I think even if we don't have Nicki, you 3 should be quorum. Does that sound right to the DPBH staff? Or anyone else who knows about open meeting law?
And I'm sorry, Jessica, how many people do we have?
So it just lists 4 for the subcommittee, 4 board members, and I think we will have 3.
Okay, so
So
this
that-
is a subcommittee, which I haven't sat on before. So as long as you have 1 notch over 50%,
Mhm.
Cool.
That's-
So leave it-
and I
So-
apologize, I haven't sat on this one before and Joan is not here for me to ask, so I apologize, I don't know more, but I know it has to be 1 notch over 50%.
That's my understanding as well. So does that mean, does Shayla, is she part of that?
I mean, she'd make it 75%. Right now, we're at exactly 50%. Oh,
I'm
hurrah!
here. I've been here.
Oh, okay. Then we have plenty. So, Amy, I'll let you take it.
All right, so call to order and roll call. Did that suffice as our roll call since we did that? No. Okay, so roll call. We've got myself here, Amy Hyne-Sutherland, Shayla Holmes,
Present.
Nicki Aaker, and Erik Schoen.
I'm present, thanks.
Great. All right, thank you. So let's move to agenda item number 2. I do want to share too, I know on our agenda, we've got 12 p.m. to adjournment. I think we scheduled 2 hours for this meeting and I'm going to try to keep us to that 2 hours. I do have another hard stop meeting at 2 p.m. But I think we'll be able to accommodate that. Does that sound reasonable, Jessica, that we'll keep it to 2?
Hey, yeah, I just threw a wrinkle in there before you came on, though. I have to get off at 1. I don't have the option. I don't have the option to go later, so I apologize.
No, that's all right. So let's do,
Amy, I just have another quick question. So Laura Yanes is here as a board member. I don't know how that impacts quorum if she's not listed as a member of the subcommittee. But if Erik were to leave, potentially you still have quorum. I don't know.
okay. So for roll call then, Laura Yanes, just in case we can.
Here.
Great. So, okay, so we've got, okay, so do we have someone on who can tell us whether that's okay or not to continue with the meeting? Since we will have a quorum of board members throughout, even though it's not the ones on that agenda.
Well, and I don't know if it during the meeting, like in the meeting minutes for the overall policy board, I said that I would participate too. So we at least have it in there that I signed up.
Oh, perfect. Okay. All right. Well, I think we're good. Let's go ahead and move forward. I think that's, you know, in good faith, right? Shared everyone that wanted to be in it at the last policy board meeting. We have those minutes. Okay. And then
And Amy, I'm sorry to butt in. I'm just gonna clarify just to be on the safe side. So when you
Okay.
guys set up the subcommittee, are you just going by members or are you going by facilities that have to be represented?
It was just by board members.
Then I think that's fine then.
Okay, perfect. Thank you. All right, so we're going to move to item 2, public comment. Any public comment? Okay, we'll have a public comment again at the end of the meeting, so there'll be more opportunity. Let's move to 3, informational overview of models and best practices for housing individuals with behavioral health issues. Ariana Saunders, Corporation for Supportive Housing. I'll turn it over to you. Thank you.
Hi, thank you all so much. Good afternoon. As it says, my name is Ariana Saunders, and I'm a senior program manager with the Corporation for Supportive Housing, or CSH. And so I have a short presentation planned, if that's okay. Can I share my screen and go
That's
over?
fantastic. Yep,
Okay.
absolutely.
Oh, it says, Jessica, are you the host? I need.
Try again.
There you go. Thank you. Psychic. Okay, thanks so much. Okay, so yes, as I said, I'm with Corporation for Supportive Housing, and just happy to be with you all. Thank you, Jessica, for inviting me to share with you all a little bit about what we do, specifically around what we've learned over the years for supportive housing and best practices around supportive housing, especially those for those who are experiencing or dealing with the symptoms and behaviors related to a serious mental illness. Just for background on myself, I got into supportive housing doing that in a different state. I won't name any other state because Nevada is the most important, but I worked in supportive housing, and we actually housed folks. That was the population that we housed were folks that were diagnosed with a serious mental illness, or those Access 1 diagnoses. And then back when we used accesses. And then when I moved to Nevada, I had the pleasure of working with Jessica as a fellow behavioral health coordinator for Clark County for the Southern Board. So very passionate about this work, very passionate about helping Nevada improve how we better serve folks that are struggling with mental illness and just improving our behavioral health system overall. And I'm really passionate about because I see supportive housing as a very successful intervention to support just those same individuals. So very excited to be here with you all to share that with you. I have to, just out of obligation, because this is my job, just share with you who we are, CSH. We are a nonprofit, and so we, as the title says, our passion is around supportive housing, but we are basically a national nonprofit that is working with communities and stakeholders in various communities to help build up their various systems, so they are able to better serve those that are most in need of services, specifically those who are in need of supportive housing. And so we do that through training and education. We have a training center that provides a ton of training about supportive housing, as well as for folks that are actually doing supportive housing, direct service staff, both direct service personnel and supervisors in leadership. We also have a lending arm, which a lot of people don't know about, but we also provide project initiation loans and other loans to kind of help pencil out supportive housing projects, because we do recognize that there isn't a ton of funding that goes towards supportive housing. So we do have a lending arm. We are a CDFI that lends as well, that does loans for those that are trying to pencil out their programs and being able to build more supportive housing in their communities. We also do a lot of around policy reform. So we both do federal, state, and local policy reform. We do a lot of education and advocacy around that. And I'll share a little bit about how we're doing that in Nevada. And then also we do consulting and technical assistance, which is what it sounds like. We work with communities, providers, to provide them that direct technical assistance or support that's needed. What I like to look at it as, having been a provider, is trying to do what we can to add capacity, because providers are often overwhelmed and don't have the space and the time to maybe sit back and do some of that planning and other type of work that we often are brought in to help them with. So that's my 3-second commercial. I promise I will not do any more of that. We'll just dig into what is supportive housing. I think the best way to frame this too is just wanted to give you guys some numbers about what housing looks like across Nevada. And so this is our report card that comes from the National Low Income and Housing Coalition. And so they do this annually and take stock of all the economic and measures that we know are connected to housing and give each state a report card. And so we came in 22nd. Ironically, that it's 22222 in the state. And so this just to highlight some of the numbers, essentially what this is saying is, for somebody to be able to afford a 2-bedroom apartment in Nevada, they would have to earn $21 an hour. To be able to afford that, reasonably. And what we call affordable housing is meaning that someone isn't paying more than 30% of their income towards housing and utilities, recognizing that there's a ton of other funds that folks need just to survive, but also just to thrive in their community. And so that's what this is saying essentially. And we know that our minimum wage is actually $9, $9.75, and that, you know, the average renter only earns $17 an hour. And so just to give you kind of some numbers to frame how much we are kind of in a crisis in terms of the need for supportive housing and how it relates to our workforce and how we support our workforce, but also just the access to affordable housing across our state is very limited and needed. So I can give you the website. I can also give Jessica this PowerPoint so you guys can dig more into this data. I just wanted to help frame our discussion by just letting you all know that. I know you've had presentations from the Housing Coalition, the Nevada Housing Coalition, who also has a lot more data on affordable housing in our state. But it's related because how we see housing, you know, part of supportive housing is the affordability is a huge component of it. I just wanted to give some other data that actually the director of the Southwest of my team in CSH did for us in Nevada. And this is, you know, for Southern Nevada. So, you know, I apologize. I know this is not for you all, but I think this just gives you an idea of the numbers, is that essentially what it costs to stay in UMC in our medical hospital or public medical hospital down here, 3 days there or 3 months at our local jail, the amount that it costs to do that, to house people in there and take care of somebody in those two different types of institutions is equal to a full year of supportive housing. And I just have to like say that because often folks get put off or are often dissuaded around even talking about affordable housing because it does seem very cumbersome and it does seem like it costs a lot. Yes, capital expenses are a lot in the beginning, but when we talk to ongoing support and sustainability, these are the numbers that we're talking about, right? That giving somebody an affordable place to live with the support services that they need based on the level of intensity that they need is equivalent to 3 months in jail or 3 days in a university hospital. So when we talk about cost savings or cost effectiveness, I think that's what we really want to point out there, is just how can we transition some of the funds that we're spending on these more high cost systems into more permanent sustainable solutions. Which is why I'm so passionate about supportive housing, because I've seen it work. And just, I know I don't have to convince you all, but what we also want to talk about too, and what we also get pushed back when we talk about housing first, which is the best practice that all supportive housing does and should follow, is really getting folks to understand that the housing first doesn't mean we're just putting somebody in a house or in an apartment and hoping that they succeed. It really is recognizing these, you know, hierarchy of needs that we know all folks need, and recognizing that we can't ask somebody to think about their vocational needs or focus on even a relationship, let alone manage their medication if they don't have that safety and security that we all take for granted because we have a safe and secure home to come home to. And so that's, again, one of the key things that we always like to talk about is first we need to provide people with those two bottom layers, that psychological and physical safety. Then they can start focusing on their behavioral health, their physical health, building relationships, and start exploring what a career or what a thriving lifestyle would look like for them. So that's really what we're talking about with supportive housing. So just to give you all a definition of what we're talking about when we talk about supportive housing, and I say we with CSH, but really just the field in general, folks who are involved in supportive housing one way or another, it essentially combines both affordable housing, and again, affordable means nobody's paying more than 30% of their income, along with, you know, the ability to provide services that support where they are able to, you know, remain stable, feel autonomous, independent, and live a lifestyle that is dignified, however it is best defined for them. And so really it's, again, affordability plus support services. And that's where the housing first model comes into play, is it's really about getting folks into housing, yes, as quickly as possible, getting them safe, but then we know that's when and only when they do have that safety that they can really start to focus on and think about what type of support services they need, what that would look like, and what you know, what their ongoing support is going to look like. And again, often more cost effective than asking folks to do that in a hospital and other kind of institutional settings. Any questions so far? I know I'm talking really fast. I just want to get through it because I do think we want it to be more of a conversation after the fact, but feel free to interrupt at any time. Okay. Just to clarify too, because I know there's various different housing models, and especially in the healthcare and behavioral health world, we're used to talking about different models, and specifically in Nevada. And so affordable housing is one of those, but it's essentially what I'm talking about is supportive housing minus the services. So it really is just making sure that we have plenty of housing stock for folks. If you think about those numbers I shared earlier, that people can actually afford based on their income. And so being able to make sure that we have enough of that in our community is one way to address housing instability, homelessness, and a bunch of other complex social issues. The supportive housing or support or service enriched housing is really what we're talking about right there. And that can look like different models, but that really is about, again, nobody's paying more than 30% of their income. They have a lease just like any other renter in the rental field. But what makes it unique or distinct is that that person is also accompanied by support services, often a housing specialist or a case manager that is, really directly focused on them and understanding what their needs are and getting them the support that they need. Is it, intensive treatment like an ACT team or intensive case manager? Is it connecting them just to a local therapist? Is it connecting them to, their local, house of worship? Whatever that looks like, that's going to help them feel stable and thrive. That's what that person's role is to focus on that. And I'll show you another graphic that kind of talks about what that looks like from somebody in the streets or in an institution to successfully stably housed. What we also have a lot of in our communities is rapid rehousing and transitional housing. Rapid rehousing is really the hot item right now because of all of the ARPA dollars and the CARES funds that came from HUD. The federal government is really, all of those funds have been focused on rapid rehousing. And that's really about getting people housed as quickly as possible with some support services, but it's time limited. What makes supportive housing unique is it really is permanent. You might hear people call it PSH, permanent supportive housing. The idea is people stay housed as long as they need and get that support as long as they need it. The goal is eventually we can pull that support out and that person is completely independent and paying their rent on their own. But for some folks, we know that they may need that lifelong support. And the level of intensity may vary over time, but they're always going to need some type of support, whether it's financial or services. Rapid rehousing is really for those folks who may just be, have experienced, some kind of acute issue or job loss or something like that, where they just need some additional support to get them back in stable housing. They may not necessarily have significant chronic health conditions or serious mental illness, or they may, but they're able to manage it much quicker or much in a better place to manage it on their own. And so it really is about that light touch services. And so again, it's time limited where folks get services from either 3 to 18 months, and then they're left on their own. It is successful for a significant amount of folks that are experiencing homelessness, but probably not for the folks that you're thinking about, especially those with serious mental illness, just because, as many of you I know who work in the field know, that it's hard to predict what recovery is going to look like for each individual. It's not linear, it looks different, and we can't control a ton of environmental factors that often impact somebody's recovery. So again, that's why we always advocate for permanent supportive housing, because we know that provides that person with that support as long as they need it, and there is no time pressure for them to quote unquote recover or get stable, just because the funds are no longer available to support them. Transitional housing is really a loose category for any housing, where it's, the traditional term that's often used by HUD is actually seen less and less because it's been shown to be not a very cost-effective model for supportive housing. They did a study a long time ago that showed it's actually more expensive and produces less successful results. And so HUD has stopped funding that altogether, or any new projects for that. So we're seeing less of that across the country, but especially in Nevada. But again, that really is about housing for folks. And often people kind of blend that with maybe recovery housing because it is limited to 24 months. Again, it's the same thing, but the idea here is just it's giving folks intense services so that they can get stabilized, that they can, get a handle on whatever they need to around their recovery and their finances, and then move on to a more permanent housing situation, often not supportive housing, but some independent housing. Again, it's not as cost effective because you are providing those intense services for 24 months. But also we've just proven again, because we know that there's no magic number to somebody's recovery, that it often proves to not be as effective. Folks often enter homelessness again or get reinstitutionalized. Because they often, encumber some kind of crisis or just weren't to a place that you would want somebody to be after those services are pulled out or they're asked to move out of that transitional housing situation. That's kind of the spectrum that we often operate in CSH and in homeless services when it comes to supportive housing or any type of housing options for somebody that's either in the shelter or living in the streets. We do have other forms of housing in Nevada and across the country that you might also be more familiar with. We have boarding care or group homes. I think that's often what our CBLAs would be qualified under, the community-based living arrangements that Nevada operates or supports. And so that often is where it's actually a person pays more significant amount of their income or whatever the going rate is for that service or intervention. But what's different than that from supportive housing is instead of a lease that's, gives them the same rights and responsibilities as any other renter, there's usually a service agreement and they have limited rights, meaning they have to adhere to whatever their treatment plan is, or whatever that service agreement is to remain in that housing arrangement. What's again unique with supportive housing is because it is housing first, engaging in services or specific type of services or adhering to a certain treatment plan is completely separate from that person being able to maintain their housing. And again, that's what we've seen work and be successful because we know, again, folks may struggle with what is the appropriate course of treatment for them. And we want to give people that ability to have small successes, but also if there is a misstep for them to never feel like they're going to lose their home and lose that stability that we know that they need to then pick themselves up again and find, the next path or a more appropriate form of treatment for them. And so not saying that this doesn't work for folks and it isn't successful, it is, but we just know that but the real point here for me is choice, is folks need choice and we need options and we need a continuum of options for folks. And this is not going to work for everybody. A lot of folks will want more independence. A lot of folks may want to stay within their community or within, the county or the community or neighborhood that they grew up in. And so not being able to provide that choice for them is often a struggle for folks who are forced to live in some of these other living arrangements because they don't have those options. Assisted living, I think we're all familiar with that. Again, it's really an agreement and folks have to adhere to all the agreement based on the operator and whatever their rules are. I hear a lot of folks with these and especially with recovery homes, often too, the pushback too is it doesn't give them some of the community integration that they would like because there's things around curfews and having to check in that folks aren't able to go out into the community, visit family, visit friends as freely as they would like to. Recovery homes is very similar. And so again, it's basically maybe transitional housing, but again, the focus here is on recovery. Often sobriety is meaning clean or sober is a requirement for them to stay in this housing. Again, so it's not following the housing model policy and it's not as flexible in terms of being able to pick the neighborhood or the home that they want to live in. And the other ones, nursing homes and other institutions are just the other models is, the intensity increases for somebody's need that some of these tend to be better options for folks who may need more intense services or have limited abilities to maybe engage in some of that independent living skills that we know folks need. So for supportive housing, what we're looking at is really it's here to serve anybody that's experiencing homelessness currently right now, chronic homelessness by HUD's definition, meaning that they've been living on the streets or home not meant for human habitation, which could be a shelter, for more than a year, or they've had 3 or more episodes that add up to 12 months. So the chronicity part is length of time. And on top of that, that they have to have a disabling condition, which could be a chronic health condition or a mental health condition, substance use disorder, any of those, anything that is prohibiting them from being able to maintain a consistent income or job. It's for folks that cycle in and out of many institutions. We have a lot of great models that focus on those folks called frequent users. And it's really targeting those folks to break that cycle of them in and out of jails or hospitals and getting them into a stable home. Again, those intensive support services that they need to break that cycle and become independent and focus on their recovery. We do have a lot of supportive housing models that are best suited for those who have an intellectual or disabling condition or developmental disability diagnosis. For those who have chronic health conditions, those who are discharged from other systems of care. I often think of folks that are coming out of our child welfare system, who we often call transitional age youth. So those 18 to 24 that, don't have maybe some of that support that a lot of us had when we were going through that transitional period, often need some of that additional supportive housing as well, is also key for folks that are exiting those institutions. And then really, the broader stroke that we say is supportive housing is literally for anybody, but for services would struggle to maintain their housing on their own. And so it really is about whoever would need that extra support, those extra services to keep them housed and help them stabilize in their own unit. That's what supportive housing is for. And so it could be any of these things, it could be all of these things, but really it's just anybody that fits under that broader category. You will see supportive housing that's targeted for specific populations, maybe based on funding or based on community need, but that's the broader category that we're often focusing on. So when we talk about supportive housing, we like to talk about kind of like it in this wheel, this kind of spoke, and really what it is, it's the housing is at the core, and then all around it is how folks then focus on what are those needs that the person needs to remain housed. Oh, sorry, I guess my PowerPoint wanted to go faster than I'm talking. And so it's really thinking about the whole person holistically. Like I said, you'll have a case manager or a housing specialist or a peer support specialist that works directly with that individual and understands what they need. What do they want? What does community engagement look like to them? Do they want to volunteer back at maybe the shelter that they once lived at? Do they want to volunteer at maybe a house of worship? Do they want to engage family again? Or start taking on some hobbies, maybe at a community center, go to an arts and crafts class. Whatever that looks like to them. For folks that maybe are exiting the child welfare system or other institutions, a lot of that focus there is on reunifying with their family, building those relationships that they may have lost or lost contact with, or had challenges in the past. And so coaching them on what it looks like to rebuild and have healthy relationships with folks in their lives again. Giving them something meaningful to do during the day is also very important. So we focus a lot on that, just training folks around budget management, how to cook some of their favorite nutritious meals. A lot of standalone supportive housing units will often offer outdoor space where folks can even garden or do other those that bring meaning to them, whatever that looks like for the individual. Of course, we're going to focus on recovery, their physical and their mental wellness. And then for those that where it makes sense and that they're interested in it, there's also a lot that goes into employment, vocational training and other types of volunteer apprenticeship opportunities that folks can get to see if employment, see what avenue of employment or what kind of career path they want to follow. And so again, it really is about getting somebody into that stable housing and then looking at them holistically and getting them those services that they need. The key behind the support side of supportive housing is that it does need to be flexible, meaning we're literally meeting folks where they are, what makes sense for them, what are their goals, and helping them move along on the timeline that makes sense for them, and not forcing them under any kind of 24-month or 9-month restrictions. It is voluntary. Again, that's back to that housing first principle of really that their housing should be totally separate. And so it's up to them to choose the services that they want and the level at which they participate in services. And then again, that it's very tenant centered, meaning it really is designed around them. We're not giving everybody the same cookie cutter treatment plan or service plan. It really is about what makes best for them, and that we're able to deliver those in flexible ways. What a big misconception or challenge for a lot of folks who are new to supportive housing is recognizing that often means actually delivering services in their unit. So it's not just site visits, it's that you're actually taking the services to the individual. And so if it's a scattered site model where there's units in various different apartment buildings or across the community, that's time spent that you have to support that's those staff to go to those people's units, visit them, and actually deliver some of the services there for them. Recognizing that for a lot of these folks, getting to different places or traveling throughout a community can be very challenging. But also for single site, it means actually building out, services maybe on the first layer. And I can share some models of what that looks like, building out services within the building. So folks literally just need to come downstairs to maybe see a case manager or a therapist or attend, an AA group. It's really about making those services as accessible to the individual as possible is, I think, a good way to think about all of that support services. So this is just a graphic that we like to share that kind of shares what the ideal path is to supportive housing. And so it really does start from before a unit is even identified or they're even accepted into a housing program. It's those outreach services. And so a lot of this is done by maybe an street outreach team that's funded through a different mechanism, but oftentimes it is done in collaboration with, once they've identified the housing program, the housing specialist or case manager will start working with the house outreach team to connect with that person and start engaging them in what we call pre-tenancy support services. So often it's about locating where that person is, building that rapport, understanding what their needs are, and trying to line up some of those services. So as soon as they are identified as soon as they identify a unit or are able to move into a unit, you can connect them to those services as soon as possible, because we recognize that change is very traumatic for a lot of folks and very challenging. And so the quicker we can connect them to services, the better. So these pre-tenancy work is really about just building that rapport, understanding somebody and being able to develop that relationship. So once they are moved in, you can develop a service plan that makes sense for them. They have that trust and that relationship built with the support service staff and the supportive housing provider, so they can connect with them, and so that they're more inclined to trust in them and engage in the services that are being offered to them, or at least we know which services, what are the best services to offer them, which it makes it just a better match all around. And so that pre-tenancy work is really about that. If it is what I think a lot is in Nevada that we have in our community is scattered site, meaning that programs have to then take the rental assistance that they have through HUD or the county or the city, and find a private landlord who will work with them to rent out to that individual. And so a lot of that pre-tenancy work too is literally escorting folks to those different apartments, showing them what those apartments look like, helping them complete a rental application, helping them understand what the lease says once they read the lease, and then all the things that they need to then move into that unit. And then once they are into that unit, then they're able to start talking about, like I said, what are your goals? What would you like to do now that you're here? What do you need in your unit to make it feel like home for you? Are there pictures that you want? Is there certain colors that you want to decorate? Again, I'm talking all ideals if resources weren't limited, but doing as much as they can to make it feel like that person's home, and then start to engage them in services, asking them if they want to, what kind of peer support would they need, or what kind of recovery support do they need? What kind of hobbies do they want? How can we help them maybe, connect them or transport them to the local community center so they can engage in some, I don't know, Zumba, whatever it looks like for that person that's going to help them feel satisfied and engaged and connected to the community is important. The goal here too is really integrating folks into the community. And so what I used to tell folks that when I worked in supportive housing is like, the goal is we're trying to work ourselves out of a job, right? And so really, yes, we're that support. And oftentimes that one consistent, non-toxic relationship that they may have in their lives when they first move into a unit, but the goal is to connect them to as many other positive relationships and providers in the community, so they no longer need us to make that, help provide that support. And so they can either become completely independent and move on, or they become less and less independent, and maybe somebody we only check in, once a week or once a month, because they've got the support that they need. They know who to call should they feel triggered. They know who to call should they have a crisis in their life. And so making sure that they feel that support and that
you're here today.
sustainability in their units. And so really all of this we're hoping leads to what we know are positive outcomes in supportive housing. And that essentially is, when we're doing that journey and they're given the quality services and support that they need, we know folks will stay housed. We know that they'll be satisfied and happy in their housing, which again is going to probably directly correlated to their ability to stay housed and their desire to want to stay housed. We often see folks increase their income or even employment. We also see folks that report that they have, they're seeing their own physical health improve as well as their mental health, their overall health or wellness is improving, I should say, and that they're also feeling more connected to social and community supports. And so again, these are like the 5 main pillars and outcomes that we want to see in supportive housing, that all of this should essentially be working towards with any and all tenants. And I just want to provide a couple examples of what that looks like, because in talking to Jessica and just, having lived here, knowing what we do have out here in Nevada, what we don't often see are buildings such as this, which are the single site supportive housing units, where all 100% of these units were dedicated to supportive housing tenants. And this is actually an example of a project that we worked with at CSH that's in Denver. And it's a really exciting project. And anytime I get a chance to talk about it, I will. The Sanderson Apartments. What they actually did is they targeted folks that were frequently utilizing their high cost systems, that were cycling in and out of their hospitals and their jails. And they used their ACT teams, assertive community treatment teams, outreach to them on the streets, worked with them, engaged them, got them housed. The ACT team follows them into the home and continues to provide services in these apartments. And what they did and what they found is, through this trauma-informed approach, through this housing-centered, housing-first approach, they actually saw a success rate of over 90% housing stability for all of their tenants over the past 5 years. And what I love about this project is they took folks that we often hear are the most difficult to serve, those who have a long history of our justice system or in institutional care, serious mental illness, serious, trauma, who often people think are resistant to services or resistant to housing, but because they use this assertive community treatment, because they really coupled behavioral health with that housing first and a trauma-informed design, which I'll show you in a little bit, and gave them that stable housing and support that they needed, they saw a really great success rate. And I can share the website to them, and we have a white paper that we wrote that really talks about the success that they had with their residents. But again, the key here, if you see the bottom, that kind of bottom picture there, at the bottom of the picture there, is they had services on site. And so the ACT team was able to literally meet the person either in their unit, or the person was able just to come down a couple flights of stairs or down the elevator and be able to see their psychiatrist or a nurse who could talk to them about maybe their blood pressure for that week because they're battling some kind of other chronic health condition or their diabetes. And so that's really the key there, is they brought the services to them. They targeted folks that were, showed a high need in terms of services, and were able to stably house them by really wrapping those services around the person and providing them a beautiful home, which I will show you is beautiful, and it's an apartment that any of us would want to live in. And so they really took a trauma-informed approach to design. And so if you'll notice on the bottom right-hand corner, a stairwell, what I loved was hearing the architect talk about how he designed this from a trauma-informed perspective. The stairwell is see-through, having recognized that a lot of people experience trauma in closed, dark spaces like a stairwell. And so just something as simple as that, having that type of glass that's stable and that's flexible, but also people could see through, was an approach to being trauma informed. They made sure that all of the hallways were brightly lit and had wide paths, so people never felt claustrophobic or closed in. On the bottom left corner is that front desk, and as you can see, they can see all the way down one hallway, and they could also see all the way down the other side of the hall. And so that line of visibility, being able to see all down the hallways, also provided that extra sense of safety that is often a core pillar of trauma-informed approach. And then as you see too, they had plenty of outdoor space for folks to live in. And actually the person that ran the person that oversaw a lot of the behavioral health services said that this little enclosed kind of courtyard proved to be more of a need than they had recognized. At first, they thought it was just going to be some outdoor space to provide folks, but what they also recognized that we often see in housing folks who have had a long experienced street homelessness for a long period of time, just the act of living indoors is very jarring to them. And so a lot of folks actually opted to sleep outside for a couple weeks before they fully felt comfortable living 24/7 in their unit, because it does feel kind of confining and closed and isolated at first. And so providing that kind of enclosed space she found to be very helpful, and just a small thing that I think folks often don't think about, that supportive housing could provide folks and ease with that transition from street homelessness, as well as recognize a trauma-informed approach for folks that are recovering from trauma. And the last model I just want to share is in Oregon, which is called the Blackburn Center. And this is actually a mixed use model, and it's really kind of a more innovative model that we're seeing pop up more and more. And I think there's a lot of opportunities for us to do that as well in Nevada, because it is hard to get folks to commit to 100% supportive housing. What a lot of folks are doing is they're doing integrated housing. And so what that looks like is it could be maybe 80% is affordable units. So just for anybody off the market, they advertise like they would any other rental unit as affordable housing. So the rent is capped. And then maybe 20% is set aside for supportive housing units for those folks that would come through maybe your coordinated entry system or other referral systems who need that extra support services. And so again, that's really key, because one, you're just adding to the overall rental market across Nevada, which we know is desperately needed, but you're also providing that support and a niche for those folks that really do need the extra support that we also know is needed for those that are experiencing street homelessness or struggling with a behavioral health diagnoses. And so what also makes Blackburn really unique and interesting is they actually integrated it with the FQHC. And so they're actually an FQHC, they're a medical provider, but they also do supportive housing. It's the operator is Central City Concern, which is a very well-known medical provider or organization there. They run a lot of clinics and behavioral health services, but what they recognize is because there was a high need in their community for supportive housing, when they were building their new FQHC, they decided to build above it several floors of supportive housing as well. One floor is, they also have some floors that are dedicated directly to medical respite or people who need more of that intensive care that are coming out of institutional or more intensive care services. And then they have some set aside for transitional. So for those folks that may be transitioning out of a unit and want to go into, more independent housing, but then they also have some set aside specifically for those who need supportive housing and who also have a substance use disorder. And so again, what makes this really interesting is they're serving multiple populations within one building. But again, because the FQHC is at the bottom layer, it makes it extremely accessible and easy for folks to be able to access, any kind of medical or behavioral health services that they need directly within their own unit without having the fear of having to engage in public transportation or anything else in terms of getting out into the community. And so again, I just think a great model. As you can see, they were able to use new market tax credits. They were able to get some grant funding, as well as some other funding. And they are also, a lot of their services are Medicaid reimbursable. So a lot of that supports the services that they offer. And so they're able to actually provide this, develop this building and provide services ongoing. So just wanted to give some examples of what it looks like, because I know we have a lot of scattered sites programs in Nevada just based on need. But this is really what we talk about best practices and ideal, because you're able to, really basically address multiple needs within a community in one building. And so I think that's just a beautiful thing that I know we desperately need in Nevada. So would love to talk to you guys more. We have suggestions on how you could get more involved and ways that you can support it. I do know that the Nevada Housing Coalition came and spoke with you all and talked about what the work that they're doing to build more affordable housing into Nevada. And I think what the opportunity we have here is, I should have shared that I'm also on the Clark County Board, Behavioral Health Board. And so what we're focusing on in Clark County Behavioral Health Board, and like what the hope would be that you all would also focus on, is being able to also support the work that the Nevada Housing Coalition is doing around getting more housing built, affordable housing built, is help couple that with the support services side and being able to advocate on how these support services can be better funded, or even increase the funding for those services across the state and in your communities. Because what we often hear from developers is, they want to develop affordable housing. They know that's a need, and there's a lot of developers that are motivated to do that. The reservation behind supportive housing is because they don't have faith that we have quality supportive housing services in Nevada. And I would love for you all to join us in the choir of echoing that that's not true. We have amazing behavioral health providers in our communities, and we do have the ability to build capacity and stand up more support services so folks can provide those services directly. It could be an ACT team, it can be intensive case management, but it can also be tenancy support services, which I know you have someone who's going to be talking about that in a second, where that doesn't often have to be by a licensed clinician, offered by a licensed clinician. It can be by a trained housing specialist or a peer support specialist. Any of those services, whether they're Medicaid reimbursed or not, can absolutely be supported and funded and provided. And we can see those same results that we're seeing in Blackburn and Sanders, and in other communities that we see where folks are able to stay housed and successfully get the services that they need. So would love for you all to join us in advocating for that and support more funding towards that. As well as you can see with supportive housing, it really is about having conversations with multiple stakeholders. So having folks like you who know about behavioral health needs of the community, working with housing providers who understand what the housing and capital side of housing needs to look like, and working with local entities, continuums of care, other funders, state funders who also have the ability to fund some of those services, and really being able to have those conversations and design plans that are going to make the most sense for your community in terms of addressing what are the highest needs, and being able to make sure that there's funding that's flexible and supportive of addressing those needs. So would love to talk more about that, but we want to open up for questions or comments.
Thank you
I talked really fast.
so much. This was fantastic.
It's a lot of information.
Fantastic overview. Thank you so much. And I think really just, speaking for myself, just what I needed to really understand kind of the range of things that we're talking about here. So thank you. If you could share your presentation with Jessica for the group, that would be fantastic. And if I could just, well, actually, I'll open it up first. Does anyone want to ask any questions?
I actually have a quick question. 2 questions. One about that 30% of their income. I think in Nevada, I've seen that often, like you take someone's disability pay and it's like, oh, it's going to be $500 a month to go into housing, and then they're left with 200. So that is not a best practice with
No.
how we've kind of currently funded that. And
No,
okay.
it doesn't meet that affordability requirement because, as you said, 200 is no one can survive off of that for a month, you know, not one individual. So it really, I don't know what it is, right? It's like 700. It should be the opposite, actually, right? So if somebody's receiving 700 in SSI, we should really only be taking, oh, don't make me do math on the fly, $200?
Probably the opposite, like you
Whatever
said.
30% of that is, yeah.
Yeah. And I just bring that up because I think that that's how we've kind of tried to get by is, well, let's use your disability paycheck and then we'll bill for Medicaid services. So I guess that's just identifying that there's a needed funding stream to make it affordable for
For the
people.
rental assistance. Yeah, and that's what it is identifying. And so, sorry, I should have included that too, is what we call 3 spokes of supportive housing. And so you have operational, which is that rental assistance. Like, how do you maintain the operating costs of any building that usually rent goes towards? You have capital, which is going to build the actual unit, or, you know, if you're building new units, and then you have the services side. And so that's what's really key, is that if folks do have no income or limited income, you know, really making sure that they don't pay more than 30%. That means you have to supplement it with some type of operational funding, which is either rental assistance through your continuums of care, your public housing authorities, or other streams. So in other communities, you know, state offices pay for a lot of it. And so that supplements, like the nonprofit who maybe owns that building is able to pay half of their operating costs because they have annual grants that maybe a funder pays for them to operate their building. And then the 30% of the income that renters pay is seen as maybe sometimes program income that they can just put back into the program, either to do other things that often funders don't pay for, recreation, pizza parties, other kinds of costs or fixes that you need to do. But yeah, that's the goal, is to find funding to support that, so nobody's in the position where they're trying to survive on $200 for 30 days.
Great. And then I just wanted to ask a question about, I'm sure, some underlying concerns about housing first. So in those buildings where there's multiple apartments and, you know, you could have a whole bunch of people come in that have substance use issues, are there issues with them all starting to use together, or like that, the supporting more substance use? So I'm just asking that because I feel like a lot of people would be concerned about that.
Yeah, thank you. That's a great question. And it's a major challenge and a myth that we have against housing first, because, you know, you're putting people into housing, and we're not saying like, please use all that you can. We're saying what housing first often uses is a harm reduction approach too. And so what it couples it with is you move somebody in and you talk to them about what they want and what they want to succeed in their life, you know. And if they're currently using and they're not sober, then the conversation is really about like, how is your use impacting your ability to have some of these successes that you want, and start engaging them in some harm reduction methodologies where maybe you use less often, you use less you use less amount. Oftentimes the conversation is about, depending on what they're using, maybe using alone or with somebody else so that you don't have fear of overdose. But the idea is you're not letting people just move in and have a free for all. A major conversation too that always happens when folks move in is what it's like to be a good neighbor and to support other folks. And so usually the conversation when I've worked in those housing, it's really frank about, this is a good neighbor, but also a good neighbor means respecting where everybody else is in their recovery journey. And so we shouldn't be outreaching to other folks to use with you. You shouldn't be asking other folks to engage in use with you. Focus on your use and how you want to reduce it there. The other thing is that their service is on site. So it's not like completely unsupervised. And that's where like the Sanderson apartments, I think, is a really great depiction of that, because security or front desk staff can see the corridors at all times, and they have cameras where they can see corridors on times. And so they can monitor if folks are coming in and out of different units and coming in and out of different units where we think people may be using or engaging in use together. And that's where folks can come in and kind of intervene and talk to folks and just have that and have those frank conversations about what that use looks like and how they may not be supporting each other in their use, or how they may be, you know, not having the most positive influences on each other. But it usually, the only time where I've seen folks move into those buildings and it is an issue is when the services aren't there. I should say. It's really not usually a free for all, and usually you do get people that are in different parts of their journey in their recovery, and so that is also key. The other thing too around Housing First is the choice factor, and so if folks do want to go somewhere where they're in an environment that's sober, we're always going to say to encourage them to do that, right? So giving them an option to do somewhere where they maybe want to be all sober. Some buildings may intentionally have floors where people who say they want to be sober or they only want to live in a sober environment, they're only placed maybe on that floor, and folks who are still in different parts of their recovery are placed in other floors, so they're not negatively impacted by each other. There's a lot of different ways you can address that, but I will say that the only time I've seen where there's challenges and maybe there's predatory behavior or other things like that is when the services aren't on site and they're not quality services, meaning they're not actively engaging folks, they're not engaging them in harm reduction, and they're not also offered 24 hours. There's not always somebody on site to kind of provide that oversight and be able to intervene before things get out of hand.
Thanks.
All right. So again, thank you so much. And I do actually have a few questions. So another one is kind of just a data question, just because we do want to bring the data that you're sharing back to the rest of the board. When you shared that 3 days at UMC is like cost-wise, same as 3 months at the jail, 1 year of supportive housing, would you be able to share that data with us too from the South? I think that would be helpful. I mean, if there's a more extended report on that. And then additionally, so are there, I imagine there's many different models of how it's staffed, but I'm trying to think about, say we said, hey, yeah, policy board says this is a great model, we're convinced this is really going to make a difference. Who's in, and I'm just curious, how does that get staffed when it's a brand new project? I would guess that developers don't, they would maybe come in to build, they wouldn't come in to do that services side.
Right.
But you'd want services, say for like the Sanderson apartments, right? You want the services on site. So can you just share what the staffing looks like when you're starting it from the ground up?
Yeah. So what we always tell folks to think about is what your target population or potential tenant population will look like. And based on that, we do have some data and best practices around what's the best staff to client or tenant ratio. So if it's people that are if it's folks that are chronically homeless that you're targeting, meaning they're coming in with at least one disabling condition, we often say a 10 or 12 tenant to one staff person ratio is really the idea. So each case manager or housing specialist would have no more than 12 folks on their caseload. And so we have information around that. And so that is going to be really important. If you're targeting folks that have a serious mental illness, we're always going to recommend that you have at least one clinician there. And so that doesn't have to be, every case manager is an LMSW, I can talk, or MS, I can't even think of all the things, MST, all the other, clinical licensure. They just have to maybe have somebody that's supervising them that can do that. So I've seen programs where maybe the supervisor is a licensed clinician, and so they're able to do some of that additional assessments and clinical interventions, but the housing specialist or the housing team are folks that, may have a college degree, may not have a college degree, may have a high school. It's really it's skill based. It's folks that can engage with folks, know how to know how to engage folks, know how to develop relationships, and know how to make connections with folks in the community, because they're not responsible for doing services directly. They're just responsible for helping connect that person to those services. So it's often can be done by peer support folks too, people with lived experience who may not have any kind of formal degree or education, but have that skills or some of that experience that's going to help them engage folks. So it really depends on the size. Folks can start really small. You can have maybe one case manager and maybe, a small building or a small program where you're only serving 10 or 15 folks. And you would just need one case manager, tenancy support specialist, housing support specialist, whatever title you want to call it. You have one direct staff person and maybe a supervisor or a clinical supervisor that can support them, can help them identify if there's any, serious medical or behavioral health needs or, warning signs that they can get that person more intense help if they need it. But that's usually where we tell folks to start, is really just making sure you have at least that, is it either 12 to 1, 15 to 1 ratio of staff. And so a handful of those support staff with a supervisor is where to start. Key.
Perfect. Okay. And then for the Sanderson one and also the one in Portland, you said was owned by the FQHC, and the Sanderson one Is that also a not-for-profit? I mean, I guess I'm wondering with the scatter sites, right? We talked about there being kind of some like building owner buy-in for scattered units. But if we did one that was like completely standalone, is that most often a not-for-profit or like a community supported project in that way?
Yeah, what often happens is the developer works to build the building, and then the non-for-profit will then take over ownership of that building and operate it ongoing. But they can also continue to own, the developer can also continue to own that building and develop into a partnership with a nonprofit that provides those support services. The developer can turn it over to a property management company or somebody else who's going to be in charge of the ongoing operating costs and management of that building. And a nonprofit comes in and does the support service side. It really depends on that relationship and that partnership, but you do have to have a developer, a nonprofit entity, or somebody who's going to do the support service side work together, as well as somebody who's going to be on the operation property management side. Sometimes it's it's the same agency. Sometimes it's 2 or 3 different agencies that work together as a team to develop it. For Sanderson, I actually believe it was another developer, not a for-profit developer, developed it, an architect designed it and developed it, but the Department of Mental Health, one of their departments or subsidiaries, took over and actually operate it and own it. And so that's why they have an ACT team that's operating in it, because they fund the ACT team that provides that ongoing support services for those tenants.
Thank you so much. And this is the last one from me, and then I'll just see if anyone else wants to share anymore. Oh my gosh, it was based on what you just said. So hold on, give me a second to come back to it. Department of Mental Health took over operations. No, it's gone. Sorry. Okay, I'll try to remember. Anyone else have any questions for Ariana? Thank you.
Oh, and thanks. Brooke has put in all the links that I talked about. My colleague Brooke, our director of our Southwest team, put in all the links in the chat for folks.
I don't have any questions. I'm just going to sign up at this point in time. So thank you for that excellent presentation. And I'm sorry, I'll just wait to get caught up for the next meeting.
Thank you.
Thank you, Erik.
Yeah, take care, everybody.
I have a question. How do you see it playing out in rural communities to keep people in their communities, but still build a successful model? Or what have you seen work in other communities?
That's a really great question. Yeah, I think, and that's often the challenge too, because you don't in rural communities have 80-unit apartment buildings that just come out of nowhere, right? And so they tend to start small. There's 2 options. There's one where you can maybe start with scattered site, where you may already have smaller apartment buildings, and the thing I have to say is it doesn't have to be apartment buildings. It could be single home families. It just depends on your target population and the type of operating costs you have. But the idea is either looking at what you have. I think for rural communities, what often we see is more of that integrated model. And I think personally, I won't say, and I know my colleague Brooke is on the line, so if she wants to say, add in, please do. But I think an integrated model is probably a more realistic option, because you need units all together anyways. So maybe it's like a 10, 20 unit building that you're building, and maybe you set aside 5 units for supportive housing and the rest is affordable housing for anybody, or people like to call it workforce housing, right? So it's like you're building affordable housing so your workforce can live and work in your community. And so the idea is creating more housing for that population, but setting aside a certain amount for affordable housing. It makes it more sustainable because it's smaller, because you may not have as large of a need in a smaller community, right? And so maybe you do just need 5 units, or maybe you need 10, but starting with 5 is just realistic. It also makes it more integrated, so folks don't feel that stigma, because when you do operate integrated, there's nothing that distinguishes between a supportive housing or a rental market or affordable housing rental market unit. All the units look the same. Everybody signs the same paperwork moving in. The only people that know the difference is the staff, so they know who is going to be outreached to for the support service side. So I think that's one option. The other option is starting small and just working with private landlords to engage them and let them understand and try to educate them on why working with a support housing program is actually more beneficial to them than renting out to the private, rental market, because you're coming with somebody that has additional supports. They have some kind of rental assistance attached to it, which is guaranteed and consistent, right? Is independent of whether or not this person has a job or not. This person's coming with rental assistance, but also if they have any fear or stigma or stereotypes around folks that have a mental illness or behavioral health or substance use disorder, is that this person is coming with additional supports that, quite frankly, a lot of folks in the community who also are struggling with similar things may not have because they aren't in a program, right? And so being able to articulate to them and advocate to them on why this is important is another thing that you can do as well. Does that answer your question? I don't know if Brooke or anyone else on the line wants to add to that, but that's just what I've seen and learned that helps for rural and smaller communities. Is you do absolutely have to start small, and there's nothing to say that supportive housing has to have X number of units. It's really what makes sense for your community, the funding that you have.
Got another question from Nicki.
Thank you very much for this presentation. It's a lot of great information. The question I have right now with the boom with rental prices, are you seeing, if you're trying to do work with private landlords, are you seeing a problem right now?
Yes.
Yeah, that's what I figured.
Yeah, and to be honest, that's why we're from CSH side, we're always advocating to add or develop a pipeline for more units to come on board, because it's become almost impossible to compete with landlords in the private market. Because as I said, oftentimes when somebody does get a housing subsidy or some type of rental assistance, they have to adhere to that fair market rent cap that HUD defines. And so landlords aren't beholden to capping their units at that. It said 2-bedroom for 1,100, right? And I don't know about you all, but I know that's impossible to attain in my community or most communities. And quite frankly, it's because landlords don't have to. We have a really, really low vacancy rate, so they're not desperate, if you will, to rent out to folks anymore. And so they can wait till somebody does come in who can afford it, and I think with the change that we're seeing with people working from home, people are moving and living in different communities, that's really sparking a challenge for a lot of folks, which is why we're saying, building new units and building a pipeline where we can obtain affordable and keep these units affordable is going to be the only way that we can offset that tight market. There are a lot of strategies that are used to engage landlords that we can do. There's a lot of incentive programs that you can do. A lot of folks are using their CARES money because HUD said it was eligible to provide signing bonuses for folks. So if you give us this unit for somebody in supportive housing, you can get a signing bonus of X amount of dollars. On top of all the things that I was just telling Laura that you can advocate. You're also going to get somebody who has guaranteed rent every month that you'll get paid on time. They're going to have assistance, so that they'll be a good neighbor and a good tenant. We're going to make sure that they don't, they understand all the rules of the lease, and they're, going to fall. You're not going to deal with any lease violations, or we'll intervene if you do have any lease violations. You can sell them all of that piece, but then we also just know that, landlords, they have their own bottom line that they have to meet too. And so fiscal incentives are always a win for folks in the private market. So being able to also do that, a mitigation fund is also very helpful too. That's often the fear of landlords is, if I let this person in and they've never lived on their own, or they're struggling with substance use or mental disorder, mental illness, what happens if they burn up the kitchen or flood the bathroom? And so having a mitigation fund, which is basically a pot of flexible funds where the landlord can then outreach and get funding to maybe make any additional repairs that go above and beyond a deposit, is also kind of incentives that we do for landlords. But sorry, the short answer to your question is yes, it's very hard, but there's two different ways to approach that.
Thank you very much for that.
All right, we've got one more question from the chat, Katie, and I think Brooke answered part of it, and then maybe we could just talk about this last part too. So Katie asked, does CSH have locations in Washoe County? Brooke shared that you support all communities nationally and that Nevada's in the Southwest geography. Katie also asked, are hospitals able to discharge to supportive housing, or are there eligibility requirements to meet that? And then just on this geography piece, I'm curious too, what support does CSH provide? You said, hey, we set up Sanderson in Colorado. What services can you provide to say a coalition like ours that was hey, we're going to try to set this up, do a kind of like consult in that capacity. So sorry, two questions,
Yeah.
the hospital question and then CSH role in development.
Yeah, so first for the hospital question, Kate, Brooke just started to answer it too, Katie. And I think it really, yeah, it depends. The supportive housing project is based on their funding or how they set up their project to target their need. But we have seen programs that do take discharges directly from the hospital. There is a best practice where a lot of supportive housing projects do what we call in-reach. And so they actually go into the hospitals or go into jails and prisons and start working with folks while they're there to get them set up. So once they are discharged, you can take them directly from the hospital and place them into a unit directly. So that is absolutely doable. It's just basically how you set up the program and just making sure that you have funding to support those types of services and that work. And obviously you need to get collaboration on the hospital side. What I found a lot of times is it's a lot of education on the hospital side in terms of the discharge planners and the social workers that are in the hospitals to educate them on what those options are. So you do have a more streamlined discharge policy. And I will say that all continuums of care are supposed to have some type of discharge planning policy and training where they do work collaboratively with those types of institutions so that they can streamline that, so that people are being entered into their coordinated entry system or whatever they need to do so folks can, because we all have the same goals. Nobody wants to see somebody discharged directly onto the streets. And so that is the goal. So yes, that can be done. Absolutely. And a lot of those frequent users programs that are designed to do that, that's exactly what they do, is they're designed to work with folks before they exit any kind of institution and house them directly, hence breaking that cycle so they don't return to the streets and then return back into the institution. And then the second thing is, yeah, CSH we do all types of consulting. So we do that. We have done very project-based consulting where we work with an entity that comes in and we work directly with them. And just basically we serve as like a consulting arm or a facilitator, convener, educator, whatever is needed to help move that project along. And so if it's working with you all to help you figure out who are the partners that you need to come in, or if you have identified a partner and it's about working directly with them and building their capacity so they understand what they need to do that, we can absolutely do that. One of our signature products that we actually do is we do supportive housing institutes, which is designed just for that. And so it's like a 12 session or 12, it can be 12 weeks or it can be spread out longer, but it's basically 12 distinct sessions where we train teams who are in the process of planning and developing supportive housing on just how to do that. And so we walk them through from, supportive housing 101 to what is it, how do you put together your support service budget, your capital budget, your operating budget? How do you make sure you have an eviction prevention policy? How are you prepared for move-in the first year? Making sure you have staff lined up, and all the way through that. And so, and then hopefully once they graduate that, they have all those plans set and they can develop that. And so that comes with, when we do institutes, it often comes with TA that helps them, after the institute, we work directly one-on-one with teams to make sure they have what they need. Is it maybe they need to connect with another funding source to pencil out their development budget, or maybe they need to develop, come up with another funding source to help their support services budget pan out because they don't have enough to fund all the folks that they want to fund, or maybe they're missing funding for specific service that they want to be able to provide. We do all of that, help them if they need help with designing policies and procedures. We do all of that. And we actually have an endorsement process too that we do, where folks can fill out an online application and submit their plans to us that we review and can also provide a quality endorsement that folks often use. We provide a letter, and so that helps them also go out and seek more funding from other folks to say, we've got this outside CSH body that has expertise in supportive housing that's saying our plans are set up for success, basically to be quality supportive housing. They usually attach that to other funding applications or RFPs so they can also hopefully acquire more funding.
Yeah, and I just wanted to insert a comment that I was talking to Ariana about this, and one successful strategy we've used with at least the program evaluators is so writing the grant and then writing CSH into the grant. Like we've been starting to write program evaluators in. So I guess my question would be if what grants there are that are appropriate for writing you into stuff, or exploring developing strategic planning for housing.
I mean, essentially, it's any funding that has an eligible cost is somewhere around capacity building or technical assistance or consulting services. We usually fall under one of those three arms. I know there's home art dollars and there's other federal funds that have come into state and local entities that do allow for those costs. And so that's where we're working in a lot of communities, is they're funding our work through that. Private grants, we've worked in Arizona, for example, we have partnerships with some of the foundations there that are funding us to do some of this work and to work directly with providers. I think it's about getting creative. And I think for us, we are also a nonprofit. So, our biggest thing is recognizing that, we know we're not usually have plentiful of resources. And so sometimes it's about just getting creative or getting like local or philanthropic kind of supporters to support that, because often the folks that are actually doing the work don't have extra funding lying around to hire a consultant to come in, right? And so
Right.
being able to partner and get those is going to be important.
Yeah, and I just wanted to throw out that I think like housing has been off of our radar. So when we've written like some of these assertive community treatment grants or et cetera, really like instead of just being hopeless about housing and going, oh, we'll figure it out afterwards, you probably could build in some of that housing technical assistance when you're like actually applying for mental health programming. So I just
Absolutely.
planting seeds or considering that.
Yeah, and I will say, looking in the health and behavioral health world, I think you'll see more opportunities for that, because as people grow and look at the social determinants of health, housing is such a huge pillar of that folks are recognizing more and more, and we're being brought into more and more conversations with managed care organizations and other folks to talk just about that. So I do think there are opportunities, as you said, Jessica, if you want to think creatively, or if you do see housing as a major spoke in the wheel of recovery for whoever you're writing that grant to serve. We're happy to help with that and support that work.
Right. Well, thank you so much, Ariana. I appreciate it. If others have more questions, maybe drop them in the chat. And
Yeah, and I'll put my email.
Thank you. That was fantastic. And I know we all learned, I definitely learned a lot. I'm sure we all learned a lot. That was great. All right, so we're going to move on to item number 4, informational overview and status update of 1915I, Kirsten Colomb, Division of Healthcare and Finance Policy.
This is Dr. Marcia, and I don't believe Kirsten is available right now. She said that she would try to jump on when she got free from her other meeting. So maybe I'll just give some opening remarks and kind of jump in on where Ariana gave such a great presentation. And we have worked with CSH previously. I think it was about 1.5 years ago, in that pandemic period for sure. And they did an institute to help some of the stakeholders, but our 1915I tenancy support program is still in a work in progress, so to speak. And we participated in a meeting with the COCs, and we've reviewed several other states, like Connecticut, Michigan, Minnesota, North Dakota, several other states that actually have 1915I tenancy support program. So we're developing a draft that would include our target population and the needs-based criteria for that program. And we also did a review using the different agencies that provide these services, like particularly the mental health, behavioral health, to see what kind of profile we would be dealing with folks that not only are homeless or near homeless, but have other criterias. such as the chronic health conditions, the behavioral health problems, mental health, substance abuse, those kind of things. So we've started that, getting information on the profiles of the actual clients that we would serve, because, you know, I think all of us in the realm of housing and supportive housing know it's difficult to be everything to everyone in that, you know, from the actual housing to the tenants, to the tenancy supports, all of that. So we've been working with Clark County and Washoe County bi-weekly to look at the infrastructure that would have to operate the program. So I believe that Kirsten is probably back. So she's probably trying to get on the meeting as we speak. But once we get a little bit closer, we would certainly appreciate the opportunity to share again a more, you know, fleshed out plan. And we'll also finalize the SPA and the policy. We'll hold a public workshop for input. But it certainly is a challenge to address both the housing crisis or needs out there, along with the tenant support that needs to go along with that. And I think that's pretty much a given, that it has to have not only the housing, but the tenancy support. So I'll let Kirsten know that we have time for her. So
it looks like Kirsten has jumped on the call.
Hi, so
Thank
sorry.
you.
Yeah. Thank you, Marcia. Yeah, sorry, I had a conflict, but thankfully it only took 13 minutes, I guess. So.
Yeah, I'm your opening act, Kirsten. So I just warmed them up for you and gave them a little bit of an overview.
Perfect. Couldn't follow anybody better. So yeah, happy to answer questions of whatever Marcia went over.
Could you just, I am not familiar with 1915I. So I've got definitely a better sense from what Marcia shared, but can you give us kind of like a brief overview of kind of the opportunities there? And it sounds like Marcia shared that it's still in progress and there'll be some public meetings on it. We, you know, could weigh in at that point, but for now, really what the goal of this committee meeting is to really understand what options we have as a policy board to recommend for advocacy purposes around housing and supportive housing. So if you could share what 1915I will touch on as it relates to supportive housing or behavioral housing, or where you see that going, even if, you know, it's not quite ready yet.
Yeah, no, good question. 1915I is such a weird term. It's very like Medicaid speak. So yeah, so good question. And I apologize if I repeat maybe something that Marcia already went over. I'm not talented enough to be on the phone in one meeting and then participate by Zoom as well. So yeah, so it's the Nevada Medicaid's tenancy support program has really been in the making for several years. It's, you know, because it's not in our typical arena of medical services, it's, you know, we're really trying to be thoughtful about how we approach implementation. And what 1915I means is that's literally the reference of the Social Security Act. The reason we are doing it under that sort of authority, because it gives us a couple of flexibilities for the population. Some of Medicaid's traditional services, particularly a lot of the rehab and behavioral health services, as I understand it, are more in our state plan services, 1905A. And so, so what the 1915 section of Social Security Act is allowing home and community-based services. Where the I is different is that it is programs for individuals that may not meet a nursing facility level of care. For anyone that might be familiar with our 1915C waivers. So oftentimes you might hear people call a 1915I waiver, but in technicality, it's not. And so it's going down that kind of authority path with CMS allows us to offer more home and community-based services for people that don't meet the traditional level of care for a nursing facility, which certainly is oftentimes, you know, this population that just really kind of needs those housing supports. And then, but they do have substantial needs. So that's sort of why we are doing that. Some other states, I know when we have worked with CSH, they were great at providing us research on what other states have had successful Medicaid tenancy supports. Some states have 1115 demonstration waivers, which you may have kind of heard, but those are, you know, a little bit different. They don't, you know, they're, because they're demonstration waivers, they're not really successful like long-term programs. So Marcia was helpful in doing the research. We compared what other 1915I programs were in the 4 other states that we looked at. So that's kind of that in terms of the flexibility, being able to kind of offer those services. And so, and then your second question, I think you might have a second question on that too.
It may have been, so thank you, that was super helpful. And also on the, okay, so this may not have been that question. I have another one, hopefully I can find the one I initially asked you. So from an advocacy perspective, like how could a policy board support that work to move it forward? You know, is there data you need? Is there letters you need? Is it already rolling and not really a legislative issue at this point and kind of a different advocacy route?
Yeah, no, okay, that was, yes, that I believe was your question. So, so in terms of legislative, you know, we already have the support. We had it as a budget initiative in our, I want to say the 19 session, we're still working on it. And then, so we already have it from a Medicaid kind of budgetary standpoint that we were given that the governor supported us and our, you know, having that as one of our decision units that got funded. And then also in the 19 session, I believe, Senator Canizaro and Ratty kind of worked on a bill too. I'll probably get the number wrong, but to put it in our, you know, to put it in our state plan, you know, to kind of mandate us to do that. So that is also added. Medicaid doesn't have a lot of mandates in NRS, but that is one that we do have. And so, yeah, so I think in terms of, you know, why we're kind of presenting to you all today, it's not necessarily, I don't think that we need any action, but certainly more input. So just wanting to make sure if there's questions that we can help answer kind of along this process. We'll also be presenting to NACO's Human Services Administrators meeting in the next couple of weeks and continue to meet with the continuums of care to kind of finalize those details. This particular program, it's taken us a while to get off the ground because we are trying to be deliberate in how we set up the infrastructure. There's, you know, as Ariana kind of alluded to, there's really foundational processes that already exist in all of the housing options. And, you know, Medicaid we don't pay for housing. So we're trying to kind of embed the specifics of the 1915I program into the existing infrastructure that is, you know, that the COCs have with, the continuums of care that, you know, someone might not know, with their coordinated entry process and what are the existing, you know, resources and providers. So we do, you know, CSH helped us with like a Medicaid Academy a while back and trying to get providers to kind of community providers now that are providing the some of the housing services to have them come into the world of Medicaid to be a billable provider once we can get the tenancy supports on board. And so because we know it's probably the same people, we don't want to also make it really difficult. So really just working closely with the groups that already exist to not overwhelm the, you know, current infrastructure and individuals that are already working on this population, but, hopefully saying, okay, great, let's try to add on this Medicaid billable model so that all of the resources that you have, it might help alleviate, some areas that you don't get reimbursement for, essentially.
Right. And so that's like the lack of options for housing providers in our region is going to be specifically an issue because most of them are social services. And so then like getting county social services to bill for Medicaid has been a real challenge, a challenging topic for a couple of years now. And so then, and then there's the conflict of interest too, like having the people that are bringing in the referrals, also providing the services, I think is one of the issues as well. And it could, go for it.
Yeah, sort of. Yeah. So certainly with 1959, the conflict of interest is a huge component. So that's where we're trying to work on the infrastructure with Clark and Washoe and working in the rural areas to identify like the operations individuals, because as long as the individuals that we have identified in our state plan that do the operations aren't the ones that provide service, then existing providers that potentially, they could make a referral to say, hey, this person looks like they might be benefiting from tenancy supports. And they also want to be a provider, down the road to say, yes, I would love to also provide them the tenancy supports because I'm an enrolled Medicaid provider. As long as we have someone else be kind of between those 2 points, be the one that makes that determination if someone's eligible, then we'll be okay. And so, certainly in the rural areas, trying to make sure that we have an infrastructure set up so that, providers in the rurals can bill if they so choose. Ideally, we can get them to that point. And then also, make those referrals on behalf of individuals in their community too.
Mm-hmm. And it could be that they're less like non-county providers in the rurals because there's never been a funding source for this before. So this is an opportunity maybe for providers to expand to the rurals too. And then I was just, so I just wanted to make the connection more that, like Ariana was, when I was talking to Ariana about this presentation, she sees 1959 as this great opportunity to really provide exactly what we were talking about, the support services, and they're habilitative, not rehabilitative. So they could potentially be permanent based on the people's needs and disabilities. So that's why like the two pieces are kind of amazing right now that we have this opportunity in Nevada anyway. And then I guess I just have one quick question. Sarah put in here, do you anticipate the next biennial budget will include 1959 funded services? I heard that 1959 has a limited capacity for how many individuals it can serve right now. I'm just going to say, and then you could.
Yeah, so the 1915C waivers have slots associated with them, but because 1959 is technically a state plan option, we can't put, there's no cost neutrality associated with, we can't put limits like we do on the C waiver. So that's also, sort of one benefit of doing it. So once we kind of have it in our budget, as I understand it, but not that smart enough to work in fiscal, it's, it's kind of in our budget and going forward. So it should be there for future biennia to be able to utilize because we have the authorization for it.
Great. So that was an inaccurate rumor that I heard. That because it's almost like a service, like providing outpatient therapy. So if the person meets the criteria and is approved, it's not like a waiver situation where there's going to be a wait list or anything.
Correct. Yeah. Now we do have other 1959 programs. So this will technically be our third. We have one for specialized foster care. And we have one for our adult day healthcare and habilitation services that are targeted to individuals with traumatic brain injury and acquired brain injury. So yes, correct. That's where it can, sometimes people can get confused. So that our 1915C can have that. So CMS does allow us to have it be limiting and to put a cap essentially on it, but because that's what's waiving the Medicaid state plan, that's what the waivers allow you to waive essentially. But the 1959 is a state plan option. It just allows us to offer home and community based. So yes, you can't, there's no cost neutrality components and there's no, we can't put caps on it because it's technically an unlimited state plan service. If someone, to your point, if someone meets the target criteria and then needs base or kind of those two things.
Awesome. I just have one more quick question, Amy. For dementia, so there's this whole conversation happening in the dementia world. And I know that this is a little off target, but people with dementia are vulnerable individuals that have behavioral health issues as well. So I guess just putting it out, maybe this is more to Ariana, or I guess also to Kirsten. I think I asked you before, because we have the same issue with people in hospitals, right? They get stuck in hospitals that have mild, moderate, more severe dementia, could return home, but there's no support services for people with dementia. So is A, supportive housing applicable to people with dementia? And then B, is 1915I something that could be explored for the population with dementia?
So I'll defer to Ariana for the supportive housing because I don't know supportive housing very well. But in terms of the target population that we were looking at, so it's age 18 and over, they have to be Medicaid eligible. So if, just to remind everybody on that, it's not like the waivers where the waivers have a higher income and the waiver helps you become Medicaid eligible. You have to be Medicaid eligible, like no matter what, regardless of the tenancy supports. And then, so the other component we were looking at is have a chronic health condition, including substance use disorder, mental illness, and then be within the categories of homelessness. So so certainly wouldn't exclude someone. The tenancy supports is really related to the housing. It's not related to any like personal care services that they may need. But certainly once you get someone housed and, then those more activities of daily living can be far more successful than they can be when someone's not housed. If that helps. Yeah.
You want me to answer the supportive housing? Yeah, it can. And I think related to what Kirsten was saying is that often what we've seen is, because it is something that is experienced a lot, especially folks who've experienced chronic homelessness. And so I think single site is more appropriate because you want somebody who's, has that extra safety built in. But they also often will do, is like Kirsten was saying, is get additional support as they need it, as if it becomes more challenging or as they, their abilities decline, then they can get that additional home-based support. They may or may not be referred to more intensive level of care, but people who have a diagnosis of dementia are absolutely served in supportive housing.
Great, thank you.
Okay, excellent. Well, thank you so much. We really appreciate Kirsten and also Marcia. Thank you. If there are any other questions, please do drop them in the chat. And if there's kind of a preferred contact, we would love to just, have your contact info. If there's additional questions after the presentation, if you could drop that in the chat as well, or if there's another avenue you'd like people to direct questions to. You had mentioned input is helpful for you at this point. So, if when we bring this back to the policy board, we have other board members with input, let us know where to get that, or who to get that to, I should say. And then next we've got, 5 for possible action, identify knowledge gaps and additional presenters for future committee meetings if needed, develop recommendations and vote to approve housing subcommittee recommendations to the Northern Regional Behavioral Health Policy Board. So if I can just open it up to the floor to give us input, anyone on the call, any of our presenters, the goal for us is to really understand the range of models available, the range of services we can tap into. What recommendations should we be making on behalf of our behavioral health community, or I should say our community who accesses behavioral services? What other presentations do you think we might need? What more information do you think we might need before we, feel comfortable saying, okay, here's what we're recommending as a board?
This is Elaine from Banner Churchill Community Hospital. Are we addressing, or has it been addressed already, emergency housing? Because all these programs sound really nice, but like I need something now. And in our community, we don't have that. And not only do we not have that, we don't have a mechanism for, hotel vouchers, and these weekly motels are like $400 a week. So even someone with an income, that's very difficult. But even people that are willing to pay and can, there's still not, there's nothing available. So I'm interested more in emergency housing opportunities, because as handling the discharges here, the hospital, or we get them all the time and there's nowhere to go.
Yeah. Okay. Thank you for raising that. So
Brooke raised her hand. Brooke,
perfect. Yeah, Brooke, do you have a separate question, or could you share a little bit about Elaine's question?
Can you all hear me?
Yes.
Okay. Thank you so much. And Elaine, I empathize. I think absolutely what you're saying is necessary. And for those who don't know me, Brooke Page, I'm part of Ariana's team with the Corporation for Supportive Housing. And I think the biggest advocacy that we're recommending is really understanding the individual needs of the spectrum of the community. And so in Northern Nevada, looking at the rural population, looking at our, rural, urban, frontier, all of the different dynamics that exist, and really honing in on what the true need is for this population, the supportive housing specific population, the folks that need emergency resources. How do we really understand the population that we're talking about, and how many units and resources do we need? Because I think without that quantitative data, it's difficult for us to quantify how we approach advocacy on what to ask for, and to sort of prioritize where we build our infrastructure. And so kind of creating the necessary resources to do that emergency response, we absolutely need to do that. We need to address diversion, prevention, emergency resources, in addition to thinking about our permanent housing resources as well, because we don't want to put people in an emergency setting and have no place to throughput and put them to a permanent option. And so kind of creating those opportunities for us to create this healthy community infrastructure requires us to, one, understand what the need is. And so part of what we're advocating for is to do a specific supportive housing needs assessment. A lot of the assessments that we have seen from statewide or in community tends to focus on affordable housing generally, and there hasn't been this drill down focus on the populations that are homeless and require co-occurring conditions, or have some of these very difficult barriers that are preventing them from getting into housing. Who is that population? What are the inflows from the emergency rooms, from our justice systems, from our psychiatric facilities that are contributing to the need in our communities? And so looking at all of those various different systems and helping us really think about this more broadly helps us then advocate to these other systems that are also contributing to the problem, as well as honing in on really what is the need in our community and how do we develop that infrastructure.
Thank you, Brooke.
Also, I don't see anyone from Churchill County Social Services Housing on this, because they have that data.
Yeah.
I would be surprised. Well, no. I see Diana on here. Yeah, they would have that data. I would be very surprised if they didn't.
Yeah, and I was going to recommend, actually, if the board decides to do another one of these committees, it'd be great to get input from the rural continuum of care, and all the housing providers associated with that. So Elaine, that's a good point.
I'm actually in the meeting for that reason. Jackie asked me to participate. She's like, you're the housing counselor here. It's important for you to be in that meeting and hear, all this some beautiful and great information. I love the changes that are happening, the things that, people are doing in different places, things that we could take from and improve or apply here in our county, without taking away from the ladies and their presentation. I'm on board with the same thing Elaine said. We struggle because there's two types of housing I encounter. There is homeless people with mental health issues and substance abuse that need a place, and it's hard to tell them to, kick the drugs, go to treatment when they don't even have a place to sleep. I mean, that's kind of hard to focus on addressing something when they don't have a place to, have shelter, a place where they're not running, where they're not in fear. that kind of thing. And then you have your seniors who are being displaced because a lot of the properties are increasing the rent. Contracts are coming up, and some people have the right, it's their property, they want to charge more rent, they know they can't. A lot of people moving out here for more affordable housing from California. And you have seniors who are in small, here, at least in this county, small trailers that are falling apart, and they're now on fixed incomes and they can't afford to buy a new one or fix that one they have. So now they're displaced and they're looking to us to help them find housing. And, you know, some of these people will get $800, maybe $900 a month, if that, with, you know, maybe anywhere from $20 to $200 in food stamps, and that's it. And they have to pay a rental fee. The low income apartments are 2 years out the waiting list. So there is no housing. It's extremely hard to help these people find housing. And I think more critical are those seniors. To me, everybody's critical who doesn't have a roof over their head, you know, but the seniors to me are critical because some of them are Elaine's clients. They're coming out of the hospital. They just had critical, you know, procedures, or they're fragile and they have nowhere to go and we have nowhere to put them. Some of the ideas are, let's get them in a car and drive them over to the shelter in Reno. That's not really a solution. That's not helpful. That's just passing our problem to the next place. So I'm looking forward to anything that could resolve that. Those two issues would be amazing here in our county.
Okay.
This is
So-
Anna, and I think that echoes for even Carson City. We have the same exact issue. Housing is very limited. Our seniors, once again, are suffering as well, just because they're being priced out of the units. The affordable housing that we do have, the landlords want to pick and choose who they want to put in. Even for our motels, they're asking for 2 times the motel rent. I mean, if you look at one of our motel rooms here in Carson City, they're going from $950 to $1,165 for a studio that doesn't even have a kitchen. It's just a bathroom and a room. That's the same exact thing with us. And even though we do have a shelter, it's full 99% of the time. And when there's one bed available, we have somebody that takes it, you know, right away. So there's really no availability.
Brooke, do you want to go ahead? I see you still, I'm not sure if it's your hands up from before or if you've got some additional insight for us.
Oh, I'm sorry, it was from before.
Oh, okay, that's okay.
But I'll
Shayla,
just-
how about you?
Thanks, Amy. I would just want, when you're talking about recommendations to our board and next steps, and I probably should have been taking notes because it's a ton of information, but what I feel like we're still lacking, because I feel like I have much better knowledge as far as how the 1915I can be utilized. I feel like I have a ton more knowledge from Ariana, and I appreciate her doing that presentation. But what I'm still not bridging the gap on is how we incentivize or get from that image to our rural communities. So like the supportive housing and those apartment complexes. I mean, yes, gold standard. How do I get that? So how do we incentivize developers? How do we get that in our rural area? Because when I think of that, and you think of your metro areas, and I think of Reno, when they're reusing some of those, you know, old spaces and converting it to those, and I think about our region that we have and the areas we have in our region, we're really limited in that capacity. So I would really like to have some conversation. I don't know who we ask, but how do we build the capacity? And how is it the economic community? Is it the development community? How do we get those dollars active in our communities to build those spaces? I think everybody that's invested in it, I mean, you hear Diana, you hear all these other folks talking about the need, and I think we're all bought into the need. That's why we have the subcommittee. I think we all see that need. We heard some great ways to provide support to help folks with behavioral health issues maintain, but we still don't have those structures. So even with the 1915I, which I am I've been a part of those conversations for a long time. I'm excited to see it finally be implemented. But as I'm thinking of that as a housing case management provider, is I don't have anybody to refer to for that supportive piece. And so how do we build up? So, I mean, in addition to the presentation for Ariana, how do we build the capacity? How do we get those structures? How do we move that piece forward in our rural communities? Because that's really, I mean, yes, right. I think as a board, we recommend these things, but just recommending them, what's the action item? What are we recommending to get there? Because then the other piece on like the 1915I, how do we incentivize providers? Right now, we lack providers in our region to be able to do the most basic services for folks with behavioral health issues and in-home care providers. So that's great that we'd have a funding mechanism, but what provider is going to come out to be able to utilize that funding mechanism? Because having a way for them to be able to get paid is great, but is that going to be enough to get them out here? So I don't know if we need to be looking to providers that are providing these services in surrounding areas and talk to them about what it would take for it to be helpful to get them out here. I think we need to have some research as far as who's invested in these structures, who's become these providers, talk to them and get them maybe at our next meeting to say, why not rural, or what will it take to get you rural? And then that would be our recommendations, I think, as far as how we go forward. So I think this is a great start. We know what the end goal is. We know what good looks like, but I think we've got some gaps in between.
Mm-hmm. For sure. Okay. I'm taking notes on that, and I'll kind of sum up what you've shared as recommendations, and then additionally what we had heard from Diana and also Brooke, but I've got a couple more questions on the floor. So Elaine.
So I wanted to answer that question about the who. And as far as I'm concerned, is when I look at the realtors in just Churchill County alone, and all of the signs that are up that says house for sale, house for rent, really this is going to boil down to money. When I look at any property and land that's available to build on, who's going to buy it? And then getting these contractors, they're building subdivisions and stuff all over Northern Nevada. Getting with those contractors, like you said, bringing them to the table and saying, what is it going to cost? What is it going to take for you to come and build that apartment complex that y'all building in Sparks right out here in Churchill County or in Lyon County in Fernley, to be able to house people? Somebody's building something in Fernley right over next to the Walgreens. Mm-hmm. So there's people building things. They're just not building it here, and they're not building it to where they are incentivized to make it affordable, because they're trying to make $1. So if someone has an apartment complex and they're charging $1,200 a month for the rent, well, if that could be busted down to $600, because the money that's in this pot somewhere that's available for housing, that it goes to that particular apartment owner, then that makes that rent affordable for people that are trying to get it. In terms of the services, for example, in Churchill County, we have resource liaisons. We have community health workers with the coalition. To get more of those people to help these property owners with the case management services, it's going to cost money. Even right now, when Diana was talking about the things that our seniors need, we can't even get out here care providers to keep people in their own home, because these companies in Reno won't even pay the folks mileage to come out here to actually care for the people. So the service is available. They don't have to reinvent the wheel. So the bottom line is, it's going to be that money being allocated to people, and the incentive is going to be money.
Yeah, so, and I was gonna actually, like, with the Northern Board, to Shayla's point about trying to draw people out, that's something to consider, you know, about how you're talking about the workforce and paying them a higher rate. That's just something to think about, I guess, when Kirsten's asking for that.
Nicki, we've got you, Nicki, next.
Thanks. So here in Carson, we do have a development that's in process. That we've been working on this for quite a while. And what the city did was the city provided land. And then the developer has secured their funding for development. And what it's going to boil down to is mixed usage. And I sure wish when we first started this project, you know, I had all this information, because we could have kind of maybe stuck a couple supportive units in there. Not saying that we can't, but that is one thing that we started looking at many years ago, was what land does the city own that could support a project? And I'm not saying a project like, you know, a low income, you know, everybody's going to be low income, because like I said, it's a mixed use. So individuals may not even, by looking at it, know that some of those units are for low income, or what we're talking about, workforce housing. So that's one way that we have started working on it, and more to come once we get this up and going. So the developer's developing it, and then they have a management company. And I could talk with them and see if they would be willing to come and talk to the group.
Thanks, Nicki. I think that would be great. That would be really helpful. It is looking like, I think we're going to need for sure a second meeting. I don't think that we should be voting on, you know, any sort of resolutions today. But if we could, you know, think about for a next follow-up meeting, having that developer representation, you know, having that economic side, helping us understand what funds need to be brought to the table. Also, the idea of thinking about, you know, each city in our rural area taking a look at, similar to what Carson City did, right? Like, what land do you have available? So for our next meeting, I think one of, if they can come speak with us, that would be great. And then additionally, for everyone that is on the call, if there is a representative from your city or county that can come to that next meeting, that can get that invite, then they'll hear how, you know, how that went in Carson from a developer, and they can ask questions. Another thing I would just want to highlight here real quick is that on the emergency housing recommendation that Elaine brought up, does anyone on the call know of models for emergency housing that we could invite someone to come share with us what's working in rural areas for emergency housing, perhaps in other states? Or Jessica, could me and you get together and look at who might be a good presenter on that, or what information we might be able to get together?
Yeah, and I wonder, well, first of all, I love your idea about the counties, because Churchill County actually has done some really innovative stuff with the land trust. So we could maybe get Shannon, and then Katrina Peters in Washoe County. They could at least say what Washoe County's done, and I think hopefully have a frank discussion about what has been right about that, and maybe lessons learned as they've taken a stab at that. And I'd imagine CSH, I just wanted to throw out that I'm sure they have information on emergency housing as well. So I don't know.
Sarah shared the Empowerment Center Women's Recovery Organization is developing housing in Reno now. Yeah, so we can invite them. I think that would be great. First Story, they gave a presentation at the State of the Counties, and they seem locked in to understanding exactly what land they have available. They have their whole team trained on being able to answer calls 24 hours in case a developer wants to come in. I mean, they were really proactive about bringing businesses in. So I think having some story representation may also help us figure out what infrastructure might be needed to get those projects rolling. And then also Brooke, her suggestion about the need for a specific housing needs assessment, you know, and then both Elaine and Diana mentioned that some of that data may already be available, but figuring out what does it look like to conduct that assessment, and who who's able to contribute data and who else needs to go out and collect it, or, you know.
And just throwing it out there, this is what I was trying to talk about program evaluators. For so long, we're like, we have these tools in the community and let's try to put them together. But there's people where we could probably pay CSH for a housing assessment. And that's where it's like, how do we start looking for grants for them to do their work, as opposed to us trying to like build this with rocks, which I feel like we often do.
So if she's still on, Ariana, could we pay CSH? Could someone pay CSH for that kind of assessment? And if so, how much is it? Or how I mean, I don't know if that's on the spot. I mean, I imagine you have to look into some things, but if, you know, that's probably important information for us to know, right? For us to tangibly be able to move forward with something like that.
Yeah, absolutely. That's right in the wheelhouse of the type of work that CSH does. So we can do that. I think, yeah, it just depends on the nature of the engagement. So we're consulting firms, so it's usually based on either the deliverable based and how much time and staff we would need to dedicate to it. So it would just be a conversation about what you have available and what we need to collect, and we can give you a quote or estimate.
Okay, great. Okay, so being sensitive to time here, Diana, I think Diana's got a question, and then I am still going to try to hold us to that 2 p.m. So Diana, go ahead, and then we'll
yeah, two quick things. One may not apply to what we're trying to kind of pinpoint down here, and I agree we need another meeting. We shouldn't make decisions because we do need more pieces. As a county, we do collect housing data. We do collect a lot of information. I would have to check with Jackie and Shannon to see if that information can be shared without disclosing people's information. I believe we could, because I think we do have to report that data for some of our funding and all that. The second thing, I wanted to piggyback on something Elaine said about providers and the reimbursements that we get. That's why I'm here working for the county, because I was working for an agency. I was being reimbursed through Medicaid, and you don't get paid for transportation. You don't get paid for the time you have to write notes. There's a lot of things you don't get paid for. And that also, I was put in a position where I had to hire and supervise people. And it's challenging to hire people with, you're bringing in someone at a low wage or minimum wage that you expect or require them to have a higher level of skill to work with people with dementia, Alzheimer's, substance abuse. So that's something important, is matching the income to the kind of providers you need and you want in your community working with the people. Because if you don't have that, we're going to fail. We're not going to provide the quality of service that these people really need. And that's why I think we have a lot of agencies have that revolving door, and they lose a lot of people, and you just don't get, you know, results that way. So those are just the two things I wanted to put out there to be considered. Thank you.
Thank you. Thank you. Okay. So with that in mind, with all of these ideas in mind, for agenda for next meeting, so let's move it on to having another meeting. We'll probably need 2, because I think this is at least 4 suggestions, all of them very meaty. We had 2 presentations today, took the whole time, right? And I do want us to have time to discuss. So let's plan for emergency housing presentation, a need for specific housing needs assessment, discussion, incentivizing for developers and kind of that economic side, and then also incentivizing of providers and what would that take in getting those voices. But 2 of those for the next meeting, 2 for the one after it. So we have time to really discuss. And I think we'll decide which 2 based on who's available first, right? What makes sense. And then does that work? Does that sound good? Any other suggestions on that? Diana, go ahead. Oh, or maybe you still have your hand up from before. I don't know.
Sorry, no, I don't have any questions.
No,
Thank you.
Okay, perfect. Okay, so if that works for everyone, let's move to the next item, which is public comment. Any more public comment? Or any public comment, I guess you should say. Okay, all right. Well, thank you. Thank you to our presenters. Thank you to everyone who came today. For continuity's sake, I really want to encourage everyone to come to the following meeting, right? We get a lot more momentum when we're able to, you know, kind of piggyback on each other's ideas, having heard the previous information, and also encourage you to share the meeting invite with people that you think can also contribute to the discussion next time. And then Jessica, does it sound good? I'll work with you on that next agenda and presenters.
Yeah, I'll follow up with you. We'll schedule it all.
Awesome. Okay. Well, thanks everyone. We're
Yeah.
pretty close to 2 o'clock. That worked out. Okay. Thank you. Sorry if we had to rush at the end, but we'll keep the conversation going. Thank you.